let's talk a little data. So back to our liver metastatic patient, sort of the move in liver-directed therapy. Our IR guys have been there to help us in the refractory setting for a long time with various forms of embolization. The Y90 data, new frontline studies looking at the impact earlier on. Richard, what's your all's approach to in the liver-dominant patient for early liver consolidation, if you will?
So there's data that was presented last year at ASCO, the data using SIRSPHERE in upfront setting, where they included a patient with mostly liver-dominant disease, but they did, about 40% of the patient did have extrahepatic disease as well. And the primary endpoint of that trial was they basically were randomized in chemotherapy plus minus SIRSPHERE. I think they gave one dose upfront, and that was it. And what they found out was that overall survival was PFS, which they did not meet. However, when they looked at the progression-free survival in the liver, there was a dramatic improvement of up to 8 months in the liver only. And that makes sense because you're using Y90 to attack the liver directly, which I think clearly makes sense.
Well, it tells us also that the stuff works,
yeah,
right? I mean, sometimes I wonder if what we're doing has an impact.
Right.
Yeah.
So, in our practice, we typically don't use local therapy up front for 2 reasons. Number one is that I'm a little bit concerned about long-term toxicity of this. So I've used it in the second line, third line more than the first line. And second thing is that we don't have any OS data, overall survival data. We know that most of the patient will succumb because of the liver disease. So if this PFS is true, this should translate into overall survival. But that's the data hopefully will be presented sometime this year or next year.
Our IR guys are pretty eager to jump on this and use this early on. I share your concerns about the tox. Are there patients where you might say, no, I think you should do this?
Well, I have certainly considered it. The problem with that study is there isn't an overall PFS benefit. I mean, the liver-specific finding is interesting and encouraging because you hope it works that way, but they don't have a significant benefit overall on PFS. And so I am curious to see what the survival data are. It's an important study. I would like to see studies where we figure out how to select the patients as opposed to globally give it to patients, right? And that really speaks to the question you're asking me, John, which is, how do you decide who to do it? And we all have our intuition about what to do. We really need studies.
Yeah. Tony, anybody? I mean, I was thinking big, bulky liver disease that responds a little to frontline therapy. Yeah. Maybe you pile on with this kind of approach.
No, I'm gonna, I agree with Charlie that unless we see an impact on survival, these numbers look interesting and it tells us this is a viable option. But until we see that we're actually changing the course of the disease by improving survival, at this point of time, I would not recommend this in the first line in combination with chemotherapy for all the concerns raised.
So is this the kind of, you send a patient to discuss with IR or you don't send them?
I am lucky in the sense that our radiation oncologist is actually a pretty big expert in this type of radioembolization approach, and so he does discuss it with the patient, then discuss it back with me. You always worry a little bit sometimes that when you send somebody to a person that does a procedure, they're going to do the procedure, and you definitely want to be able to have that dialogue. I personally use this, but I do use it in later lines of therapy where you have the liver disease dominating the course of how that patient's doing, because I do believe that you do see a response in the liver. And where people ran into trouble in the SURFLOCK study is extrahepatic disease that progressed. And so maybe this is a sign that we need to use this in later lines of therapy.